You.
Thanks, Zoe. I really appreciate the opportunity to see you all. And again, just grateful for that partnership and collaboration because, Zoe mentioned I'm still around and I always make bad jokes and say that's because who would really want this job? Uh, it is definitely a interesting time and a transitional period. So thank you for your kindness. And if you didn't have the opportunity to go to the NAMI summit last week, thanks, Zoe, again for the shout out. I was trying to be low key. You put me on blast. That's that's okay. That's what we're there for, is to network. So just a few updates internally. I'm sure you've all heard we have a new DMHA division director. Sarah Sailors came from DCS. And Becky obviously is still around, and she is into the chief of staff, back into the chief of staff position after serving as the interim director during the Braun transition time. So we're grateful, as Zoe mentioned, that Becky's still around because she has many, many years of institutional knowledge for the division, but excited to bring Sarah on. You may know her from her tenure, her very long tenure in the Department of Child Services, where she served as a senior advisor and deputy director. So again, it's less of a learning curve when you've worked in state government as long as Sarah has, but now she has to understand the processes within the division, which is significantly different than that of the child services world. So we're still going to have some learning curve, but we're excited to have Sarah come on, and she's been very receptive to the programs that we're continuing and trying to maintain in this whirlwind of legislative battling for funds, etc. So as far as the state hospitals go, we are currently at 85% occupancy, which is kind of the industry standard on inpatient units. And we did drive down from that near 90% occupancy, which was dangerously high for the acuity of the patients we're serving. Richmond still remains my fullest hospital. They're at 93% occupancy right now. So it's incredibly busy at all locations across the state. And currently, this morning, we had 143 on the admissions wait list, and we have 86 currently on our discharge wait list. And I'm going to share the network average wait times, but I know there's always a one-off. There's some outliers that somebody will go, well, I have someone who's been waiting for the X days, but the average wait right now for youth patients is 33 days, and the average SMI wait time across the network is 39 days. Again, when you're you have to keep the bottlenecks from occurring on both ends. So in order for us to admit, we have to maintain discharge. And unfortunately, and I'm certain it'll come up in discussions today, the forensic numbers continue to rise. So you've probably heard me say this a million times at various events. In the last decade, we've seen a 398% increase in forensic referrals, which is astonishing, but not outside of the national trends and norms. Now, our state we have a lot of interested parties in reforming the competency pathway, a lot of misinformation that people have about forensic clients and trying to dispel those myths, but certainly that is impacting our ability to meet the needs of some of our just clean civil commitment clients. But we have done a lot of collaboration too and worked with partners in some pretty new ways for the state hospital. I think for the last 6 years, people have just kind of went, really, another pilot, Katrina? Thanks a lot. But we have to try things differently, different approaches to move some clients in and out of our system. So those are kind of the big data points, if you will. The other thing you may have heard about is we're making some massive technology enhancements in our system. So the referrals all come through a repository that we call Viewpoint, and it was exceptionally dated software. So we have worked really hard the last couple years about Viewpoint enhancements, and the basis of it is we want to make it a simpler process and make the system work for us. And especially for your gatekeepers, because a lot of times what we found was the system was inefficient and we were sending it back, or we didn't have enough information because there wasn't a drop down box. And it sounds really simple, but software systems are incredibly expensive to update and to reform. So right now they're currently working on some Viewpoint enhancements that will make that referral process tenfold easier for your gatekeepers. So we're pretty excited about that. And obviously, the more efficient we get with the software, then the better the process will flow and less of those referrals coming back needing additional information. So that's really what we're working on at central office. We did lose a couple positions in the central office. So our director of operations, Jeff Wedding, took the superintendent job at the two Evansville campuses. And at this time, those positions are not being filled at the state. So that means Katrina's doing some operational work in addition to some administrative work. Our forensic alternative restorations manager has also put in her notice. We think we can absorb those duties internally. And maybe reclassify that position in hopes that we'll get some additional support at the central office. So to put that in context, that leaves myself, my assistant director, Asia Barton, who does all of the gatekeeping liaison work with the community mental health centers. And then we have a controller that works for the state hospitals and a contract specialist. So that's my team at the central office. Most other states have a full C-suite in their central office. So keep in mind that there's just a handful of us doing this work at the central office, but certainly customer service driven, collaborative, partnership driven. So if there's anything you need, please don't hesitate to reach out to myself or to my team so that we can continue to meet the why statement. I love that, Zoe. So thank you. Thank you for that. The other thing that is worth sharing is we have really, again, seen a paradigm shift, if you will, as far as getting really creative and meeting people where they're at in that discharge process. So recently we've established some partnerships with other entities, non-contractual, which I think is also really impressive to note, that we didn't have to pay them to partner with us, but we developed a program with Brickyard, and they provide skilled nursing services across the state. And they have been phenomenal partners with us for our aging and geriatric, our medically frail population in the state hospitals. Most of them have been with us a very, very long time. And their psychiatric conditions became secondary to their physical health. So meeting level of care for skilled nursing, Brickyard has been an amazing partner in moving some folks from the state hospital to skilled nursing. And I think it was really just having the conversations that did the trick. And then we brought them into the hospital so that they could see the patients, and that changed their perception. So they've taken, I want to say, right around 10, 15 patients in the last 3 or 4 months, which has been phenomenal in movement. And we basically just offered them some support. So you can, if you take this patient out, and when you have a patient who's been in the state hospital for many years, transitioning them into a new environment can stimulate some behaviors, if you will. And so we offered services for their treatment teams to collaborate with our treatment teams, to make it comfortable and comforting to those older adults that we were transitioning out. And so we did the same thing on the youth side. Went and talked to YOC and said, when we have kids that need step down services, would you be willing to partner if we gave you the same collaborative services? And an unwritten rule of, if things go south in 72 hours, we'll take them back, just so that they had some type of understanding that we're in this together. We haven't yet done the step down with YOC, but we've begun the conversations that mirror what we did with Brickyard. So again, just doing things we've never done before in an effort to keep people at the right level of care. And I say it over and over and over and over, it's so important to have the right patient at the right time in the right place, because if not, we just jam it up for those who do need those services. So I'm super proud of those efforts that have been made to partner and think outside of the box, if you will. Another thing that we have worked on is the central office is building out in those viewpoint enhancements, an alert system for forensic referral. So if a client comes to me incompetent to stand trial, we keep them beyond the 180 days that we're allotted to restore them. They transition to a civil commitment at that point if they're not restorable. But the CMHCs have no idea that these folks are from their catchment area. So we're building an alert system in Viewpoint that will alert CMHCs if a forensic client is in their geographical area, so that nobody's getting kind of blindsided by, oh, this person is in your catchment area and you had no idea that they were even in the state hospital because they entered through the forensic pathway as opposed to the civil. So I'm really excited about that alert system, where it will send the emails via the Viewpoint system to your gatekeepers ahead of time instead of after the fact. So those simple things that we've worked really hard on, with the resources that we have. And then the other thing I just wanted to talk about is, how do we continue to collaborate as an infrastructure, as a behavioral health infrastructure system, and everything happens good at the local level. It's not at the state level. It's what you all do with your local leaders, your local courts, and building those partnerships and relationships. And I was so impressed with the conversations this past week at NAMI, and all of the work that the CMHCs are doing at the local level all over the state. So that was a great presentation, Zoe, that you and Brittany did, and really highlighting the work across the state, because that is so, so important, whether it's the AOT opportunities, especially with your SMI clients who struggle with med compliance instead of the outpatient commitment after a state hospital. Being very proactive and doing it on the front end, I think, is for everyone's best interest. And then in addition, just seeing some of the remarkable work that you all are doing. I had the opportunity to go to the ribbon cutting for the Stride Center at Centerstone in Richmond, and that was an impressive turnout. In addition, working alongside partners at Adult and Child on some really hard cases, and the gatekeeper there has just really been phenomenal, to work on cases that traditionally have been a little scary. And I have taken a personal interest in one particular case, that I knew would be difficult to discharge because he's a lifetime parolee. Um, and those are hard to place cases, and usually people just go, oh, no thanks. And so I have to give shout out to Adult and Child, because Selma was like, we can find a place. And we did, until something else came up, and we'll continue to work through those barriers. But for me to advocate, I did take on a handful of the most difficult to discharge cases in the state. so that really I can work alongside those local level social workers with the CMHCs. And then I can firsthand say, yeah, I know how hard this is because I've been in there looking for a placement, or, how do we fund someone whose Social Security can't be turned on until they're in the community, um, with the limited resources we have. And if you've if you've seen House Bill 1001, you know it does not look like it's going to improve. So that creativity and the collaborations we are building here, I think, are just they're incredibly important for the future of our state and for our infrastructure. So with that, I'm going to pause for a minute because I'm sure there's questions and dialoguing, and I haven't had a chance to read the chat. So.
Yeah, well, just really I've kept up on the chat, and just really a lot of thank yous for you and your work. I mean, carrying a caseload, running the, state hospital system, managing things in central office. We know that that's a heavy lift. And so just a lot of thank yous to you for that work. And then also two things I wanted to know is the Indiana Council meets with Katrina and some members of her team. And our next meeting is April 2nd. And this is really, it's different than the gatekeeper meeting. Like the gatekeeper meetings kind of to talk through those in particular, operation issues as they apply to gatekeeper. The state hospital meeting, a lot of CEOs attend and operation folks, clinical directors. And we actually, through that meeting, have been able to determine a couple policy gaps that Katrina and I are working on together. For example, one of them is when Medicaid was slow, when we couldn't get people on their coverage and needing to work with Gainwell, and sometimes that becomes an issue. So then her and I are both able to work both inside and outside to help in making those improvements. So it's more for kind of those larger scale operations issues, policy gaps, to get an update and come together to help in those conversations. So our next meeting is April 2nd. And that, if you're interested, reach out to Denise Wade, and she will make sure that you're included on that invite. It also started around our issues and concerns around workforce, both at the state hospital and within our system, and how can we work together, because sometimes workforce was not allowing admissions and that sort of thing. So I think that has improved a little bit, but it's really been beneficial, I think, and Katrina, agree or disagree with me, to kind of uncover some of those bigger concerns that we might need to do policy, legislatively, or work with administratively. Because like I tell Katrina, she might not be able to lobby, but we can. And so that becomes helpful, right, in that partnership. So what questions do you guys have for Katrina?
Can I go first?
Of course.
First, I just want to say, Katrina, thanks so much. I mean, I feel like run into the most complicated situations, and you and your team just really help us kind of work through them. And I just really appreciate you. I have just an observation more than a question. I think, we continue to struggle, I'm sure like everyone does, with people who have sexually based or violent based offenses coming out of the state hospital and finding placement. That gets really hard when, we're accountable for the gatekeeper metrics. And so just want to make that observation. Same with the IDD population. Like, we run into situations all the time where they've burned all their bridges with rest care and other places, and they're not really able to live alone. But the thing that we're probably running into the most, and this is, again, not a criticism of the state hospital system at all, just an observation. It's the youth that we know need to be somewhere more permanent and not having placement for them. And it feels like often we're just waiting for them to continue to fail before we can get them to the right level of care. And so I just want to plant that seed. I don't know what the solution is, but it feels like a miss in a lot of cases. but can't say enough about how great you are to work with and how great your team is, and just really appreciate you and your flexibility.
Thanks, Beth. Certainly, I'm seeing the exact same barriers that you just mentioned there. Now, Governor Holcomb had the high acuity kids work group that was multi-agency. Some of that has continued. I don't know all of the intricacies on every piece of the project, but on my side, I still participate in a rapid response team, which is kind of ironic because nothing I do is rapid in the state hospitals, at least not by my standards. But we're staffing 2 or 3 kids a week. And so the other trend with youth that Beth mentioned that we're finding is, again, it's exceptionally low IQ kids that have some over sexualized behaviors, and this was a new one for me yesterday. As a matter of fact, they said, well, they're too acute for juvenile detention. And I'm like, wow, okay, so there's a major gap when they're too acute for acute, they're too acute for juvenile detention. And where are we supposed to put them? And I have 71 youth beds and they're full. I mean, they're full and waitlisted. So the space is packed full. And I think it's indicative of something much larger. And my research brain keeps going, we're going to have a major problem as these infants that were born NAS and opioid addicted continue to show impulsive behaviors, and need some services, because I don't know that it's all conduct disorder, my least favorite diagnosis in the entire DSM. But I think there's some neurobiological stuff that we're going to have to address as a behavioral health system, and recognizing their inability to control the impulses because of the damage that was done in utero.
And that's good to know, Katrina. That's actually a question I have for Sarah on Thursday when I have coffee with her, is that high acuity group. So it is still taking place. And so just kind of, we might have them as a guest to kind of connect, because I know our youth services committee has also, like, what can we do in some of these situations, right? And collaboratively working with the state. So I will try to get more information and try to have a follow-up on that. Beth, thank you for bringing that up. What other questions does the group have? Okay, well then I'm gonna rapid fire updates. Before I do that, if we could all take a moment to thank Katrina for her time and her dedication to those that we serve, and her really bi-directional communication that really helps in making sure that people get the services that they need. So thank you, Katrina, for being our speaker. And you can stay on for updates, because these probably impact you as well. So um, so I wanted
Good morning.
to,
I'm sorry.
yes,
Zoe. Hi, this is Dr. Rogers at Edgewater.
Dr.
How are
Rogers.
you?
Yeah, I'm
Hey,
good.
I was trying to get myself off of mute, but got another meet. But anyway,
Fine.
I wanted to ask the question. We had an individual, we did, the interview, and they had someone coming that needed to come from the state hospital, but we wanted them to come to see the facility first, and just to see, to get him acclimated. And then I guess we were told that no, they won't bring him down. We'd have to come and get him and then bring him back.
Hmm.
So I guess I was just a little concerned, how do we get them? We want to have a smooth transition from the state hospital to us, but we also don't want to just throw them in there and say, oh, okay, hey, here you go. This is your new place. So,
Absolutely. Yeah. Dr. Rogers, if you want to send me a message offline and which hospital told you they couldn't do that, because we do LOAs all the time across the
okay.
state. So certainly just send me a message and we can work with that specific hospital, because I agree with you. It's better to prepare them it's more therapeutic for them to see that than just
Yes, it
dumping them.
is. Well, and this gentleman, I guess, had a manslaughter charge, and we just wanted to make sure that he was a good fit.
Mm-hmm.
And then we were just told no, but I will make sure that I have the director follow up and send you an email. Okay.
Perfect.
And
Sure.
then how often are we? So I thought it was yearly that we had to go out to see the individuals in the state hospital. Is it more than once a year? I mean, physically, as opposed to a Teams or a Zoom?
There needs to be contact every 90 days. That's statutorily outlined. We prefer that to be in person, but obviously, depending on locations, we can accommodate a virtual meeting as well.
Excellent. I
Yeah.
just wanted to make sure because I think we just got a message that, well, you're out of compliance. So I don't want to be out of compliance. I want to make sure that we can have, because again, it's just, and I think if they're like in Evansville or Evanston or the
Mm-hmm.
hospital that's like 5 hours away, I mean, that's poses a barrier to the gatekeeper at this particular time, but we'll figure it out. Thank you so very much.
You bet. Thank you.
Thank you, Dr. Rogers. Any other questions? Okay, I am just going to rapid fire some updates for everyone. I might not be able to get through all of this, but the slides and the presentation will be available. I just want to ensure that everyone has certain dates on their calendar coming up, because as I said, we hit March. So we are now in spring planning. So April 17th is our wonderful Racial Equity and Leadership Connection Hub. I'm really looking forward to hearing this speaker. They found this great resource about leadership development and leading through change and managing conflict. And so that is at no cost. That is for all members, so all staff to be able to attend. And we have that Zoom information and registering here on the QR code. So please join us for that. Leanne has also been super busy here because spring is the time that we recognize our members. So I did want to call attention to this. If you have people you would like to nominate, and you can nominate other CMHCs, other staff in CMHCs, people you have worked with, we are looking for the Innovation Collaboration of the Year. We are looking for the Employee of the Year. And we are looking for the CMHC Advocate of the Year. We did add a new category, and this is really to help with workforce development and getting our students and our interns connected to our system. And we would love to celebrate our Student and Intern of the Year. So please make the nominations. We have a committee that will be reviewing those nominations. We will be celebrating all nominees and winners at our May conference. And so really looking forward to our second year lifting up our system and the great work that all of you do. And then also, this will be coming out here this week. We are doing our member survey. So as we gear up for our board strategic planning meeting in June, we want to make sure to hear your feedback on how the council can best serve you. And so this is the QR code for that. And like I said, Leanne will be getting that out. We'll get the legislative stuff out to everyone. I do have one ask before we wrap up. If you have not reached out to members of your Senate appropriations, and I'll be sending CEOs individual Senate connections here this week, but if you have not reached out to your Senate appropriations staff, our legislators, and your Senate as a whole, remember our budget ask of that 53.1 million on the one pager is now on the Senate side. And so we need to get that ask on the Senate side, and it also includes that group home rate of the 42.2 million for the budget, which would help in a lot of the things that Katrina's saying from a discharge, if we're able to have more beds and have a sustainable resource in our group home setting. So I do want to call that out. If you have not done that, That is really important to do as they're gearing back up to hear budget items. And so in conclusion, I wanted to congratulate our Starbucks winner, and that is Tracy Sessions. So she will be our Starbucks winner, Tracy. And then I want to raise, I picked this cup. This is Radiance Cup. See, members with the Cup of Joe. And I just think with the sun, let's all be radiant today. And I really appreciate everyone being on. If there's anything you need, please do not hesitate to reach out. And thank you again, Katrina, for all of your hard work, and really look forward to continue to do that great work. Appreciate all of you. Have a great day. Thank you.
Hey, Zoe, one thing real quick. I just want to call attention to what Katrina just put into the chat, which
Okay.
is that a 10% cut in the state hospitals would be consistent with her closing a hospital. So when we're looking at advocacy, that might be something we want to make sure we're talking to our legislators about.
Thank you for calling that out. Got it.
I appreciate that. Thank you so much.
Yep, we got you.